Hey everybody, it's been a while since I made a video, and I changed up the way that I explain things, maybe to make it better, maybe to make it more clear, maybe to demonstrate that I've learned a few things as I practice. So it's just a few things that I wanted to kind of touch on in this latest update about chemical dependency. So the first thing is that I've been using a couple analogies to try to demonstrate what I want people to be working towards as they're addressing their chemical dependency and trying to make progress. And so the first concept that I like people to think about is that there are four gears, like a stick shift car. Not that people drive those much anymore, but the first gear is just getting started, and especially for people with opioid dependence and alcohol dependence who are using buprenorphine for medication-assisted treatment. Just get on the buprenorphine, otherwise known as Suboxone. It doesn't really matter what the dose is so much or how you take it, just kind of get the wheels in motion, kind of get first gear started and get comfortable with that, and then get ready for second gear. Now, second gear is also difficult. It is what I call consolidation. And so what I want people to do is take those multiple doses of the day where they're taking a half of Suboxone here, or a quarter there, or one before work, or one after work, or one when they feel this way, or one when they feel that way, or whatever, and consolidate it down to a single daily dose. Now, there's a few reasons why this is important. Number one is that for people who are trying to taper down, taking that little extra piece later in the day tends to keep people at the same dose because they're always taking that extra one that they're trying to get rid of, and by trying to taper down, it feels like they're giving something up. But if you consolidate it to a single daily dose, you're taking one a day, and then for a couple months or a couple weeks or however fast you're going, you take 3/4 once a day, and then half once a day, et cetera, down and down. It just makes it easier to control. But really the important thing is that we want people to get away from using a chemical to manage their emotional or physical discomfort. And so if you use the exact same dose of Suboxone, whether you have the best day of your life or the worst day of your life, and you never take another dose, then when you are having one of those bad days, instead of taking that extra Suboxone, you're maybe going swimming, or you're writing in your journal, or you're calling your sponsor, you are going to that meeting, or you're a number of different things that people use to help them use a non-chemical coping mechanism to get away from that. So if you find yourself using that buprenorphine multiple times through the day, that tends to reinforce, and I've talked about this before, but I want to touch on it again. It tends to reinforce the chemical dependency problem that that's the whole reason why we're doing this. So that's gear 2. Now gear 3 is tapering down, and people taper at different rates. I've got patients who don't taper at all, who want to stay on the same dose, and that's fine. I think most people should try to taper off, and the speed at which you taper off is dependent on a lot of factors, and I'm not particularly invested in one approach versus the other, but I think most people should try to taper off. But regardless, so first gear, get started. It doesn't really matter how you do it, just so you get started, and then second gear, consolidate. Third gear, taper. Fourth gear, now we're cruising and maintaining recovery off of Suboxone. So the other thing is that when you do take that extra dose, we're going back to second gear. People like to do things efficiently. If you're going to be taking your groceries into the refrigerator, you're going to probably grab 2 things and put them both in the refrigerator, then go one at a time. You were always thinking, okay, what's the most efficient thing for me to do? And it's very efficient to use buprenorphine. So when you're feeling stressed, or you're feeling this way or that way or whatever, that extra buprenorphine is helpful. And it's way better than relapse, so that's good. But the problem is that when you take that extra half of buprenorphine or a quarter or whatever, What you're not doing is exercising those other coping skills. So when you take that buprenorphine and it works, well, you're probably not going to go swimming, or you're not going to, you aren't going to do whatever your coping skill is, or whatever, you're not going to address the problem. And which is kind of a segue into the next concept that I've been telling people about, and that's the concept of the snowplow. So now there's no snow in Hawaii, but people will kind of get the idea here that when people are struggling with chemical dependency, they're using that chemical as their emotional escape mechanism. So rather than, as they come upon something, a relationship issue, rather than addressing it, talking with their partner, whatever, they just get emotional escape from it. They push it away with the chemical, like a big snowplow. They're just pushing one problem after the next, relationship problems, financial problems, issues at work, sometimes health problems, whatever they don't want to deal with it, push them ahead of them, and ends up you get this huge pile of problems in front of you, and then people up there looking at all those problems, holy crap, there's so many problems up there, oh man, I can't even deal. And that is when people get stuck. So many problems that they've pushed ahead of them that they just can't make progress anymore. And so when they enter the chemical dependency treatment program, the problem is that all those problems are still there. And initially, when I take away somebody's chemical escape mechanism, or what I say sometimes, I kick that crutch out, and they're wobbly, and they start reaching up there and grabbing all these problems, financial problems, legal problems, relationship problems, whatever, and taking a look at that huge pile up there, and each one of these things will be like, oh my God, I can't deal with it. It can be difficult, okay? And so you got to be patient, though. You have to understand that it will get better as you gain coping skills, as you work that pile of problems down and down, and you start making forward progress. It does get easier, but that first time, period of time can be difficult. And I want you to think about transitioning from that snowplow that's just pushing all your problems ahead of you, not really dealing with them, getting that chemical escape, getting that distance from your real life, which is up here chemically. And I want you to kind of turn into a snow blower. So as you come upon these problems, you have an internal mechanism, and that internal mechanism can be counseling, can be going to meetings, it could be a number of different things, and hopefully it is a number of different things, because what you're going to deal with at 2 o'clock in the morning is different than what you're going to, or how you're going to deal with problems at 2 o'clock in the morning is different than how you're going to deal with problems at 2 in the afternoon, and problems with your spouse are going to be different than problems with your employer. You're going to have a number of different tools in that internal mechanism. So as you come upon problems, you work it out now, and you get rid of it, and you move on to the next one, like a snowblower. And that way you're not building up all these problems in front of you. So think of this process in that way of dealing with problems, going from that snowplow, pushing things ahead, and transitioning to the snowblower. One other thing is people talk to other people, and they have experience with getting off of Suboxone. Sometimes in my practice, but most of the time not in my practice without my advice. And they say, oh, I had terrible withdrawal, or so-and-so said they had terrible withdrawal and they couldn't get off of it, et cetera, et cetera. And just the concept that I'm trying to use now is getting off a train. So if you're on a train and the train's still going and you try to get off the train, well, you're going to hurt yourself, okay? It's a lot easier to get off of a train by waiting it to come to a complete stop and just stepping off the train. So you get all these horror stories of people who are on Suboxone at high doses, and they just jump off the train. They're like, oh, this is fine, I'm just going to get off here, and they end up just getting their butts kicked. And you have to do it in a controlled way. And if you do it in a controlled way, you slowly taper down, and you step off of the Suboxone train after the train is stopped, it's smooth as butter. So when you hear these people talk about how they're difficult time getting off of Suboxone, it's multifactorial, but oftentimes people stop at a very high dose compared to what I normally recommend people stop at, because they're just anxious to kind of stop taking Suboxone. They just want to stop taking it and move on with their lives. And unfortunately, you got to wait for your brain to catch up, and you got to wait for the train to stop. The last thing that I want to say is that it's a small town, and I hear things, and my wife hears things, and and not everybody's happy with me. Sometimes people end up in my practice against their will, and they are frustrated because they feel like they've been treated unfairly, or that somehow I'm getting some financial incentive from getting people on Suboxone or what have you. And that's just simply not the case. I would love to not have any Suboxone patients, and to have no more new phone calls, and for this crisis of opioid dependency to settle down. But the reality is that people need help, and some people who need help don't know or can't recognize, or just maybe don't want to recognize that they need help. And so I've had to expand my license multiple times, from a limit of 30 patients to a limit of 100 patients, and now my limit through a special rule has been expanded to 275 patients. And I just I'm a salaried physician. If I see 0 patients a day versus 35 patients a day, it actually makes very little difference. I don't have any interest in the Suboxone manufacturers, of which there's many now. There are now 8 different manufacturers of buprenorphine of different strengths and formulations. And I like that. I seem to understand the problem of chemical dependency enough that I can be an effective provider for chemical dependency treatment, and so that's why I do it. It's certainly not for financial gain. And for those people who feel like they've been treated unfairly or whatever, I apologize. There are people who feel like they've been unfairly discharged from my practice, and I want to get well ahead of this. When somebody's discharged from my practice, it's simply because they refuse to address their chemical dependency problem. I ask them to go to meetings, or to see a counselor, or to come in more often, or to get committed to a higher intensity program, and for whatever reason, people just refuse to do it. And so they come in with continued problems with relapse and continued use, and I'm trying to get them to a path towards recovery, and they're just standing on the brakes, and they're not willing to change anything. And so I'm like, this program isn't working. You're still using. You're taking Suboxone for what? You're still using, and it doesn't seem to be helping you make progress. The other thing is that if I know for certain that somebody is not taking their buprenorphine and they're selling it or trading it, I can't have that. I can't have people hurting other members of the community with medicines that I prescribe. And so I have zero tolerance for that, and that's another reason why people may be discharged. In this last 12 months, I've seen, I think, 190 different people for Suboxone treatment for opioid dependence, and I may have discharged 1 or 2 in that 12-month period. This is not a usual thing. When somebody says I got kicked out of Chiles' program, very likely they chose to leave on their own, and it doesn't help anybody for them to be blaming their continued struggle with chemical dependency on me. I mean, I have lots of people who come in who have relapsed, and we, well, what happened, and what are we going to do next time, and let's get back on the Suboxone, and is the dose right, is your counseling right, how are you working on your coping skills, let's continue to find that path forward. That's what usually happens. I have never discharged somebody from my program for relapsing. It's just, that's not how it works. So those are the main points that I wanted to discuss. I hope that's been helpful, and if you anybody wants to have me talk about particular issues or expand upon things, I'd be happy to do that. Thanks so much.